Hello, I am Dr. Brian Swain, and I am the Medical Director of the Weight Loss Center at Murray-Calloway County Hospital, known as Bariatric Solutions. And we are here now to talk about the weight loss options that we have. And this is going to be our online seminar. We're glad that you're here with us, and we hope that this will be informative for you. And we're going to go ahead and get started. The talk is called "The Wait is Over." And the subtitle to this is weight loss surgery options. And the brief outline that we'll go through is the history and trends in obesity. And during that time, we'll sort of talk about how obesity has been treated in the past. We'll also talk about what some of the non-surgical options have been in the past and how effective those have been. We're going to talk about the current surgical options and what's available at Bariatric Solutions at Murray-Calloway County Hospital. We'll talk about how you decide to undergo surgery, why you choose a particular surgery, either sleeve gastrectomy or the Roux-en-Y gastric bypass. And then we'll talk about the keys to long-term success after weight loss surgery. That's sort of the brief outline that we're going to go through, and we'll go ahead and get started. So changing perception of the severely overweight or obese patient. So in the past, obesity was seen as a sign of weakness or failure on the individual or the patient, and people were very reluctant to talk about this with their healthcare provider for fear of judgment, and also because they basically would be told, if you'll just do diet and exercise, or if you'll just consume fewer calories than you're eating, then you'll lose weight. And weight loss surgery itself was viewed as either experimental or extreme or dangerous, and most healthcare providers really weren't on board with that. And primarily that was in the era of open surgery, where you had to be opened up in order to have that done. And fortunately, in the time of laparoscopy, that's changed considerably. Obesity is also now considered a disease, and in being a disease, it's now known to be the cause of many serious health conditions and the root cause of those. And so we've learned that if we will treat the root cause, which is the obesity itself, we're also treating those other diseases. But it is still a form of social discrimination that people have to deal with. Surgery, unfortunately, has gained acceptance as a proven form to treat the disease. And really, if you look at it statistically, it's the only proven form or method to treat the disease. But surgical treatment is not for all patients, and eligibility or appropriateness of surgery for each patient has to be determined on an individual basis. So who qualifies for weight loss surgery? So if you look at this slide, it gives you a range of BMI from normal to extremely obese. And there's going to be a box placed around those who are obese class 1 and 2, and then the extremely obese. People that are extremely obese with a BMI of 40 or greater qualify for weight loss surgery without any other comorbid conditions. Those who have a BMI of 35 or greater can have weight loss surgery if they have a significant comorbid condition like hypertension, diabetes, polycystic ovary syndrome, degenerative joint disease, depression will qualify for some, sleep apnea. Those are some of the various comorbid conditions that help people qualify for weight loss surgery. This slide is interesting, and it shows a correlation between BMI and overall comorbid conditions or overall health. And you can see that along that line of BMI between 35 and 40 is when the overall health risk dramatically increases, and that's why that's sort of that cutoff that we use for people to have surgery. Obesity is significantly linked to cancer risk, and this slide sort of goes through the different cancers and the relative risk compared to people that are not obese. And you see a 46% increased risk of endometrial cancer, 35% risk of esophageal cancer, a 28% risk of pancreatic cancer, 24% risk of kidney cancer, 21% increased risk of gallbladder cancer, and so on and so on. So pretty dramatic increased risk of a variety of cancers associated with obesity. And if you treat the obesity, that increased risk is gone. So what are some of the weight loss strategies that can be employed? We'll run through these. Primarily what's been used in the past is dietary intervention. I think most everyone who has struggled with their weight has used that in the past. And typically what you can see with that is maybe a 10% body weight reduction in 6 months. Certainly diets are prone to failure. Anyone who has been on that yo-yo of dieting, weight loss, and then weight regain can identify with that. Statistically, it's very, very difficult to have long-term success with dietary intervention alone. Physical activity certainly is great for improving your overall health, particularly your cardiovascular health, but not very good for the treatment of morbid obesity, not very good long-term success with that. Behavioral modification, and this is a structured program where you're meeting with a psychiatric provider or someone who is actually trained in behavior modification, can contribute to overall weight loss, but requires ongoing professional contact, and failure usually occurs once that contact is discontinued and can be pretty expensive as well. Drug treatments, so we're talking about things like orlistat, fen-phen, Ally, and there's many new drugs that have come to market recently. Those drugs primarily are designed for short-term weight loss with a particular goal in mind. The weight loss that's achieved is fairly modest when compared to placebo, and the long-term benefits are not really that great, and there's significant side effects that are present with many of those medications as well. I think most of us have heard of the cardiovascular effects with fen-phen and so forth. So that leaves us with weight loss surgery, and certainly it is the most effective and really the only effective long-term weight loss treatment that we have to date. Statistically, nothing comes close to the weight loss surgeries that we have in terms of managing weight and managing the comorbid conditions that go along with obesity as well. We're going to now sort of go into a phase where we're looking at the two surgical options that we have at Murray-Calloway County Hospital, the sleeve gastrectomy and the Roux-en-Y gastric bypass. And we're going to start off with the sleeve gastrectomy. It is performed laparoscopically, so what that means is it's done through 5 small incisions. You don't have to be opened up for these surgeries any longer. And with this surgery, what we do is we remove about 70-80% of the stomach. We functionally turn the stomach into a tube rather than being a sac. Your stomach holds far less than what it did before. Additionally, the several hunger hormones, one of them being ghrelin, is removed by removing that part of the stomach, and so the hunger drive is drastically reduced. You feel full with a very small amount of food, and then the calories that your body normally would consume, you're not consuming, and that calorie deficit leads to your body needing fuel that it isn't getting from your food, and then it's going to use your fat stores as fuel, and so over time your fat stores go away. This surgery does require an overnight stay. Usually people leave the hospital about 24 hours after they're admitted. What are the indications for the sleeve gastrectomy? I mean, what are the reasons we would choose this surgery over one of the other surgeries? For people that have inflammatory bowel disease, they're certainly not a candidate for a gastric bypass. People that have severe intestinal adhesions also would not be a candidate for gastric bypass, or if they're on immunosuppressive drugs or anti-inflammatory drugs as well. Or if someone just refused to have an implanted device like the lap band, they also would not be a candidate for that device, and so they would be a good candidate for the sleeve gastrectomy. Or if someone just didn't want to have a malabsorptive procedure, and many people don't, and so those people are ideal for the sleeve gastrectomy. And then if anyone had a BMI in that 50 range, certainly 50 to 60 range, they're a great candidate for the sleeve gastrectomy. And there's the lower limit of that certainly is not is 50. We certainly do this surgery on people anywhere from that 35 and above range with comorbid conditions, but we certainly find great results in the people who have that BMI in that 50 to 60 range as well. So this is a sort of a summary slide that looks at how the sleeve gastrectomy works, and then sort of after surgery what you can expect. So it is purely a restrictive procedure. It reduces hunger. It is not a reversible procedure. That part of the stomach that we staple off, that 70% that we reduce, is removed from the body and it's gone forever. So it's not a reversible procedure. It does require a 23-hour observation, or about 24 hours in the hospital. Most people are back to most of their normal activities after about a week, and pretty much full recovery in about 2 weeks. So what are the advantages of a sleeve gastrectomy over the gastric bypass? There's really not any dumping syndrome. There's no bypass component. There's no risk of intestinal obstructions from that. The risk of nutritional deficiencies that's caused by the bypass you don't have. There's no upper limit to a BMI that can be done. There's no contraindication from inflammatory bowel disease. For patients that require non-steroidal use for either rheumatoid arthritis or something of that nature, they can have this surgery done. And there is no implanted device, and many people just like that as well. What are some of the risks and complications of the surgery? Definitely like to talk about that. Many of these are theoretical risks, and the percentages that are here are national percentages. And when you compare our rate of these complications with the national percentage, we do quite favorably when compared to this. Leak rate from the staple line occurs about 2% nationwide. Our leak rate so far has been far under that. We actually have never had a leak to date. We'll knock on wood as far as that goes, but we've been very fortunate as far as that goes, and we certainly hope to maintain our 0% rate, but our leak rate is very, very low. Bleeding can occur 1.2% of the time, and that typically is from the staple line or from the cut edge of the omentum where it attaches to the stomach. It's very rare for that to happen, but it can happen and require additional surgery to go back in and fix that. Strictures of the tube can occur. That's where the sleeve that we've created becomes so tight that the food can't go through. The incidence of that is less than 1%. We've not had that particular complication here. And the 30-day mortality, or the risk of death, they have listed as 0.19%. Our risk of that is far less than that. The risk associated with any major surgery, nausea, vomiting, and infection, and the need for reoperation is there, but is extremely, extremely low with this surgery. And typically with this surgery, once you get beyond that 6-week period, you're pretty much out of any danger. One thing we have seen is a risk of gastroesophageal reflux disease being made worse by the surgery. That's a very, very rare complication, and it's typically seen in people who have significant reflux before the surgery. And in those people, we are directing them not to the sleeve, but more toward the gastric bypass. So what's the follow-up protocol with the sleeve gastrectomy? So with any surgery that you do for weight loss, follow-up is going to be key. It's going to be mandatory. You'll follow up with the surgeon or the nurse practitioner 1 week after surgery, and then at 30 days, 3, 6, and then maybe 9 months, but definitely at a year post-op, and then annually after that. You follow up with the registered dietitian for 7 visits after the surgery, and the purpose of that is to see how you're doing with your dietary recommendations, and as long as that is going well, after a year you follow up annually. If there's any questions or concerns after that annual visit, we'll follow you more closely. So the follow-up is key. I mean, this is not a fix it and forget it program that we have, we feel like that our ongoing contact with you is vital for your success. Next, we're going to talk about the Roux-en-Y gastric bypass. This surgery is very different from the sleeve gastrectomy. It is both restrictive and malabsorptive, so it has a dual function in how it works. So the first part of that is we create a small pouch at the top of the stomach. It is roughly the size of an egg, and then we go down and we divide the small intestine, and then the divided end we bring up to the pouch, and then we reconnect the bowel later down the line, and that's where the Y aspect of the Roux-en-Y comes in. It looks like a Y. It is also performed laparoscopically, and the upper pouch holds about 1 ounce of food. This is not an adjustable procedure. It is restrictive, but it is also malabsorptive, as we talked about. So real absorption of material doesn't occur till the common channel is encountered, and that's where the digestive enzymes and the food come together in the common channel. So the shorter the common channel, the more malabsorption occurs. So what are some of the complications or side effects that can occur with the gastric bypass? Dumping syndrome is one that many people have heard of. Dumping syndrome occurs where a carbohydrate meal is dumped directly into the small intestine. And what you see with that is usually flushing, tachycardia or a high heart rate. You may see sweating, abdominal pain and cramping, and then that's usually followed by diarrhea. So that's typically when people have eaten something that they're not supposed to eat. So there's good things and bad things about dumping syndrome. The bad thing is that it occurs. The good thing, it usually trains the person not to eat the thing that they're not supposed to eat. Bleeding can occur, infection, we talked about that. There's risk of that with any surgery. The risk of that is certainly fairly low, far less than 1% with this surgery. Anastomotic leaks can occur, and that's where the small intestine is either hooked to itself at the lower part or hooked to the gastric pouch at the upper part. The incidence of that is less than 1% of the time. If that occurs, it may require additional surgery to fix that. Where we hook the small intestine into the gastric pouch, that hookup can get narrow over time, and that can require dilation or additional surgery to fix that. That is also very rare. Internal hernias can occur where there's little gaps in the blood supply to the small intestine. The small intestine can actually loop through there and twist. Those are some things that occur later on, or delayed complications after the surgery. And the typical scenario of that is that the patient has lost 100, 150 pounds, they're doing great, then all of a sudden they have severe abdominal pain. In those situations, that patient needs to present to the emergency room right away because it needs to be fixed quickly. The other thing that we see, or can see, is marginal ulceration, and that's an ulcer in the small intestine right where it's hooked up to the gastric pouch. When that occurs, there can be bleeding from that, or there can be a perforation, and that perforation can require emergency surgery. So it's very important after this surgery to take your medications that are designed to prevent ulceration. The incidence of that is somewhere around 2 to 5%, and usually can be managed with medication. With any of these surgeries, there is a small risk of death. It is a fraction of 1%. The risk of death with the gastric bypass is slightly higher than it is with the sleeve gastrectomy, but it is still a fraction of 1%. So what are some of the indications for the gastric bypass? So we talked about, primarily we're using this in people that have real significant gastroesophageal reflux disease and are not a good candidate for the sleeve gastrectomy, or in people who have fairly long-standing or difficult to control diabetes. It's also good for people that have heart disease, high blood pressure, severe sleep apnea, or people who have also refuse to have an implanted device, because there's not an implanted device with this procedure either. So that's sort of a summary slide of the indications for the gastric bypass. what is the follow-up protocol for the gastric bypass? It's very similar to what it is for the sleeve gastrectomy, and follow-up with this surgery is also mandatory. You follow up interval with the surgeon and the nurse practitioner at a week, and then about a month, and then 3, 6, and 1 year post-op, and maybe 9 months post-op, depending upon how the individual patient is doing. And then 7 visits during the first year at prescribed intervals, and then every year after that, or possibly sooner, depending upon how the patient is doing. Then what's key with this surgery as well is because of the malabsorption, ongoing use of supplemental vitamins and minerals is very key, because those deficiencies can be quite significant. So with 2 surgery choices, which surgery will you choose? And many times, by the time someone comes to our practice, they have an idea of what surgery they want, and we help provide them information and then help them make a decision after that. It's very rare that we dictate to a patient what surgery they should have, but the sleeve gastrectomy and both of these surgeries are primarily designed for people that are roughly 100 pounds overweight. The gastric bypass, as I stated, we're looking for people to do this who have difficult to control diabetes, or who have significant gastroesophageal reflux disease that's difficult to control with medications, or if people just have a personal preference about which of the surgeries they would like to have. And the decision about that we usually will make in the period before surgery and in multiple consultations that we have together. Just a brief slide about bariatric surgery coverage. Generally, most insurances are going to cover bariatric surgery. There is a review process that we can help you go through to determine if you have the benefit. Just because you have the benefit does not mean that you are going to have coverage on an individual basis, and we can help determine that. We do go through a definite pre-certification process prior to surgery. The people within our office understand the appeals process and the coverage process very well. And we do have self-pay options, and many people elect to do that, seeing this as an investment in their long-term health. And we can discuss that further with you either on a face-to-face basis or over the phone if necessary. So where do we go from here? Many people have that question at this point. And so the biggest thing that we have to say at this point is that this is a lifestyle change, and requires a commitment not only to the surgery, but to ongoing medical nutrition therapy, alterations in your diet, alterations in your physical activity, and realizing that for people that struggle with their weight, that struggle doesn't end at the time of surgery, and we're here as a resource to help you with that struggle from here and forever. The next steps are an initial consultation with a nurse practitioner, and you'll have a consultation with a registered dietitian, and then you'll have the pre-surgical appointment with me, and then you have pre-operative testing and education, which is very comprehensive in nature. And typically there's a 3 to 6 month period from the time that your first contact is initiated to the time of your surgery, where we're doing ongoing education and supervised weight loss. So what are some of the keys to weight loss success? Like we said, this is a lifelong commitment, and the people who do the best understand that what they've been doing in the past certainly has not worked for them, and this is a major change, and they're willing to make that commitment, and we're here to help with that. Follow-up visits are going to be necessary. The purpose of our team is to facilitate all of that, and that's what we're here for, is that resource. Support groups are something that we offer as well, and we think they're vitally important. They're a resource to you. It's people that are either been through the process or going through the process, and being able to access people who are at a different time along this chain is very important, and I think will be something you find very beneficial as well. We do require that you attend at least one seminar prior to surgery, and then one every 6 months following surgery. That's how important we view the support groups. And that's just a little bit of a change that we made in the last little bit based upon some of the feedback we've gotten from patients who have been through it before. We thank you for considering bariatric surgery at Callaway County Hospital, and we look forward to meeting you soon.